this evening. You know, the first time that we did this, I had a great lineup of speakers, and Dr. Kelly Brogan really jumped in at the last minute and pinch hit for me when one of the speakers quit or couldn't do it last minute. And Kelly Brogan did the most epic speech. And so much so that it's had 3,000 YouTube views on our YouTube channel and growing. It was called What Functional Medicine Does to Your Brain. She is a holistic psychiatrist. We've sort of built this event around her because I'm so excited to be able to look at a new paradigm of mental health that includes a real understanding and appreciation for the placebo. It's the best medicine ever. We need to get as much of it as possible. I think we need to have a new appreciation of the interconnectedness of systems. If the microbes are in the gut and the serotonin's being made in the gut, we need to think about it's a whole body approach. So here she is, fan favorite. Please welcome Dr. Kelly Brogan. There's a clicker. Good luck. Mwah.
So we have two exhibits, Exhibit 1 and Exhibit 2, and the task is to determine which line in Exhibit 2 is the same length as that in Exhibit 1. And you're sitting at a table with 8 other people, all of whom have been prompted to give the wrong answer. And so they give all of their wrong answers, and by the time it comes to you, it turns out that a third of you will also give the wrong answer. Most of the time, despite a sense that your perceptions might be tricking you, but you have a good idea of what the right answer is. And this is an experiment conducted by Solomon Asch and discussed in a book by James Davies called Cracked. And it speaks to this idea of groupthink, this idea of bandwagon mentality, and how it might contribute to the formation of memes in healthcare. And there are many of them. Some of my favorites are that cholesterol causes heart disease, as perpetuated by the sale of statins, that exposure to germs equals infection, and that antibodies equal protection, as perpetuated by vaccines, and even that reflux is a problem with the stomach, as opposed to what we're putting in it, as perpetuated by the sale of proton pump inhibitors. And you know, what I'd like to discuss today is how there is a collusion between a field in crisis and the pharmaceutical industry, and that there are memes created around the myth of a chemical cure. And so I want to go through and demystify for you some of the misunderstandings, I believe, that have been perpetuated around the mechanism, efficacy, and safety of antidepressants, but with in mind that this applies to psychotropics on the whole, and perhaps the pharmaceutical industry at large. So, we can multitask. Okay. So the pseudo-legitimization of psychiatry really began with the inception of the Diagnostic and Statistical Manual in the 1950s. And what's a little bit hard to see at the top is that it has ballooned from 130 pages and 106 diagnoses in 1952 to now 886 pages and 374 diagnoses today. And this inclusion or exclusion has not been based on science or evidence, but rather opinion and consensus, as was the case in 1973 when homosexuality was cast out of the book based on a survey. So the question is, does this matching between symptoms, descriptions, and patients, does it actually work? And so one of my favorite experiments was conducted in the 1970s by Dr. Roshan. So he dispatched 7 academicians to different hospitals, and he told them, tell one lie. Tell the interviewing psychiatrist that you hear a voice that says thud in your head. And that's the only lie that they told. And to the shock and horror of everyone involved in this experiment, all of the academicians were hospitalized, many for multiple months, and all of them were treated with medication psychotropics. So one hospital was outraged, and they said, well, send us some more fakes. And after a month, they claimed to have found 42 fake patients but Dr. Roshan hadn't sent any more. And it's illustrative in many ways of the lack of reliability and validity of this impressionistic diagnostic system. And in fact, subsequent studies have demonstrated that there is a concordance of about 32 to 42% between one psychiatrist and another, that it depends on what country they're living in, and multiple other subjective variables. So even if there were reliability and validity, the question would still remain, have we identified a real pathology with an identifiable cause? And the problem is that when you don't have evidence and science, you create a vacuum for the pharmaceutical industry to enter. And some very important people are very concerned, including the head of the NIMH and former contributors to DSM. According to Dr. Daniel Carlott, psychiatry has become a proving ground for outrageous manipulations of science in the service of profit. So how did the pharmaceutical industry get this foothold? Well, the beginnings are rather humble. So the meme of serotonin imbalance as it relates to depression really began with these two contributing factors. One was a hypothesis-driven review from the 1960s by Dr. Schildkraut. It's a hypothesis. And the second really was the observation that anti-tubercular drugs had mood-altering effects transiently in some patients, and that they were known to interfere with the monoamine system. But 6 decades of research since have not validated this model. And in many ways, this is an example of the dangers of deductive reasoning. So it's not that dissimilar to considering the fact that somebody who is shy and socially anxious goes to a party and they drink a couple glasses of alcohol and they feel better. And Dr. David Healy has described the fact that if you were to do a 6-week placebo-controlled trial of alcohol for anxiety, it's plausible that not only would it demonstrate some efficacy, but then it would be recommended for long-term chronic care, obviously with some considerable dangers. And based on these types of trials and these early trials, the net has been cast to encompass an impossibly broad list of diagnoses that are now all reduced to something to do with serotonin. And the problem is that your toe can hurt because you have an infection, your toe can hurt because somebody's standing on it, or your toe can hurt because you have a string tied around it, and the hurting isn't the problem, right? So this is how the illusion is sold to us. So I want to talk a little bit about the short-term trials that are done, and the fact that direct-to-consumer advertising and physician courtship by pharmaceutical companies collude in a very powerful partnership to perpetuate this. So these companies have to be fairly crafty in manifesting the outcomes they're interested in. So here are some of the things that they do. Placebo washout, replacement of non-responders. They allow sedative medications such as benzodiazepines concurrent to study medications. And perhaps most importantly, and on the subject of placebos, they break blind by using totally inert placebos so that subjects actually have a good idea that they've received the quote-unquote active treatment when they begin to have side effects. So the pioneer in this field is Dr. Irving Kirsch, and he has, through 2 meta-analyses, one that unearthed unpublished data, demonstrated that only 27% of the therapeutic effect of antidepressants is actually attributable to the drug's action, okay? And that when he includes this unpublished data, the difference on a 52-point Hamilton scale is 1.7 points, which is insignificant on a clinical basis, according to NICE guidelines, to demonstrate efficacy of this medication. And these findings have been echoed. There were trials that demonstrated a 10% difference between placebo and antidepressant effect, and of course the largest non-industry funded trial, costing the public a cool $35 million, demonstrated that at 12 months, those receiving citalopram, those receiving an SSRI, were only remitted at a rate of 3%. Okay, so what of this unpublished data? Well, a now famous study from 2008 looked at 74 studies that substantiated the approval of 12 antidepressants. And they found that of 38 positive trials, let's see if this makes sense. Okay, so in the blue, 38 positive trials suggesting that antidepressants were effective. 37 were published, right? They're proud of their work. 1 was unpublished, okay? Of the negative trials, 22 were unpublished. 3 were published, and 11 were published actually as positive trials. So the data was functionally manipulated to represent a different outcome. And here's the problem. So we've been convinced by smoke and mirrors that these medications represent a panacea, and we prescribe them for patients in crisis. But then what? So Robert Whitaker has led us down this path and shown us that, in fact, when we look at untreated naturalistic, retrospective, and prospective studies, we find that they all demonstrate better functional outcomes when patients are either briefly treated or not treated at all. And then, in fact, we may have turned what used to be a single episode illness with a 67% recovery rate in 6 months into a recurrent, chronic, and debilitating condition. And the fact remains that we don't have a long-term study to demonstrate superior outcomes with long-term medication treatment. But the people I've mentioned who are raising these concerns aren't functional medicine practitioners. They're not holistically oriented. They're not alternative medicine doctors. So I have even more concerns. And here are some of the papers that substantiate my concerns. I'm worried about the effects of mitochondrial functioning, unintended consequences of these medications, because it turns out that all classes of psychotropics have been documented to damage mitochondria. What about how antidepressants affect the HPA axis? What they do to cortisol and cortisol receptor sensitivity? How they reduce resting in stimulated HPA axis function? Does this have something to do with why it's so difficult to come off these medications? And what about methylation? What about the effects potentially in utero of antidepressant exposure with regard to epigenetic expression? Oh, sorry, I didn't forward it. Okay. This is just a long title. That's what I was talking about. Okay. So this is sort of the notion that I put forth to my patients when I try and explain what we can expect when I taper them off medication, at least to some extent. It's this idea of oppositional tolerance. And in many ways, it's evidence that we are not fixing an imbalance, that we are creating an imbalance, and that the body is forced to adapt to exposure to these chemicals, and that adaptation is very difficult to undo. So it's something like squeezing a spring for a long time and then just letting it rock out of your fingers. So it's been demonstrated through 46 studies that patients' risk of relapse is proportional to how perturbing at the receptor level the medication is. So that these medications, when withdrawn, promote relapse, which makes sense if you understand the basics of homeostasis, right? To advance it. Okay. So when I meet a patient who is symptomatic, or when I think about taking them off medication, I think about this concept of resilience. I think about the fact that the body wants to adapt and that it's constantly seeking this adaptation. But I believe that only functional medicine really gives us the tools to approach this issue, that there's no room for this concept really in allopathic medicine. And so when I think about depression and anxiety, it looks a lot more like this. And it's a system-wide consideration. I think about gut dysbiosis, I think about oxidative damage, I think about neurotransmitter precursors and cofactors, and I think about the endocrine system. And I think about a common driver, which is, as far as we understand today, likely to be inflammation. I think about hormonal imbalance as a cascade of secondary manifestations of inflammation that are trafficked between the gut and the brain. And I think about inflammation as being caused by dietary antigens, stress, and toxic exposures. But these really aren't my ideas. In fact, it's been about 25 years since the first proposal of the cytokine theory of depression was put forth in the literature, and this idea that increased inflammation accesses the brain, affects neurochemicals, and cellular stress response. Early incarnations of this theory have revolved around this notion of sickness behavior, around the overlap between systemic illness, inflammatory cytokine trafficking, and depressive symptoms such as lethargy, sleep disturbance, anhedonia, loss of libido, lack of social interest, anorexia. So the question is really, are we looking at a formerly adaptive inflammatory response that's now being triggered by modern exposures? And in the literature, there is an effort towards identifying biomarkers and looking at the fact that at this point we have identified that things like CRP and IL-1, IL-6, these cytokines, TNF-alpha, that they have a linear relationship, a predictive relationship, and that resolution of these biomarkers actually confers symptomatic relief. And perhaps even for the most dreaded of outcomes in psychiatry, we should be looking at inflammatory markers as predictive. Perhaps we can use chemokines. We can use our understanding of the inflammatory response system to help us distinguish between different presentations, as is discussed in this paper that's only 2 weeks old. And the fact is that we know that bodily inflammation, often triggered, as far as we understand, by gut exposure to things like grains, dairy, sugar, preservatives, distorted fats, that these can change the integrity of the gut lining and can allow access of things like bacterial lipopolysaccharide and luminal contents into systemic circulation, where that response is translated to the brain through the immune system. Right? So it hasn't been too long that we knew that there was an immune system in the brain, and it turns out that there is, and the microglia are the hubs. And so now we have this amazingly elegant description of how inflammation can produce things like quinolinic acid and NMDA agonist, can produce symptoms like anxiety, agitation, and depression. And what can we do about it? Right? So that's probably what most people want to know. And the fact is that we have basis, we have the budding knowledge in the literature, even in randomized controlled trials, of how we can use natural medicine to intervene symptomatically. And this is not even taking the whole patient and biochemical individuality into account. So this is just using natural supplements as medicines, which is really not the functional medicine approach. But nonetheless, we have a safer path. We can use omega-3s, for example, to prevent a known inflammatory type of depression such as that induced by treatment for hepatitis. We can use curcumin or turmeric. Based on this trial, it has a 62.5% efficacy, and it outpaced Prozac and placebo and has an incomparable safety profile. And maybe that's because of the elegance of its multimodal effects: anti-inflammatory, neuroprotective, neurochemical, and antioxidant. Can we use probiotics? This is the notion of psychobiotics, so using therapeutic doses of beneficial bacteria to modulate behavior. And at this point, we have animal studies to substantiate the role for the vagus nerve in communicating information from the gut microbiota to the brain. And we even have randomized control trials in adults that demonstrate the alleviation of anxiety after 30 days on a probiotic versus placebo. But the fact is that we can't just be throwing probiotics at people. We have to back up, and we have to think about, how do we cultivate this resilience? How do we engage preventive medicine? And this is where my activism around birthing comes to the fore, because the neonatal origins and antenatal origins of adult disease are something that are becoming so much more clear at this point. And antepartum diet, delivery method, and breastfeeding are the ways that we can control for these variables. Because it becomes a lot more complicated as an adult to try and fix this up. And influences such as glyphosate and Roundup, endocrine disrupting chemicals, they collude with diet to stress and diminish the integrity of our bacterial ecosystem. So what are the tools, the fundamental tools that I do employ? The first is diet, okay? So when I meet a patient, I spend 30 days trying to overhaul what they're putting in their body from a nutritional standpoint. And I'm interested in really radical simplicity. I'm interested in culling from our body of knowledge about what may have been ancestral exposures, what are some threads in different cultures that have avoided, traditional cultures that have avoided degenerative diseases, and I look to control their blood sugar balance and to promote natural fats in their diet, because in some ways I'm treating an organ that is 60% fat by dry weight, so it's a priority for me to keep those cell membranes healthy. And I also think about how do I send the body a signal of safety so that it can call off the dogs. And the best way that we can do that is what we already discussed. So it's the relaxation response, which has been studied for 4 decades, and Herbert Benson Institute has pioneered a lot of the research showing that even in 20 minutes of a guided meditation, we can change inflammatory gene expression. And then, of course, there's exercise, there's movement. The simplicity of that is really overwhelming. So, to close, my belief is that when we look at the whole person living in their environment and we leverage our understanding of what their epigenome is expecting to encounter, when we look at it from that perspective, we see that forcing the system to adapt to a pharmaceutical-grade chemical in many ways could be considered an assault on their humanity. So I think that it's really time to bring a more enlightened approach to these patients, and I think you're all up for the task. So thank you.
Kelly, thank you so much for sharing that. Actually, we don't have a mic. Gabe, can we have the hand mic? Now, you've become a bit of an internet celebrity talking about pseudoscience, and just in the concept of what you've just spoken about, maybe you could just sort of speak a little bit to pseudoscience as how people interpret it now and what you feel like it really is.
So I think we're... Do I need it?
You need it for the video.
Oh, okay. Testing? Yes. Okay. So I think we're at a bit of a crossroads because we've exposed some of the limitations of the gold standard randomized placebo-controlled trial. In many ways, how subject to potential corruption and manipulation it can be, but even in its design, what its limitations are. But it's still the only language that we have by which to communicate about treatment. And I think that there are some elements of medicine that really make themselves evident without having to, demonstrate through a trial that they are relevant. And, there's some examples of this, like seatbelts and parachutes. I mean, things that declare, efficacy with an N of 1 or 2 rather than waiting for 10, 20,000 people in randomized trials to demonstrate the relevance of a treatment. So I think that we're at a crossroads where we really need to innovate about how to demonstrate, scientifically hopefully, how to demonstrate what treatments make sense. And I don't think we're there yet, but I think it's about opening up our understanding of how to look at what treatment should really consist of, and probably looking at preventive medicine first and foremost.
That's a great point. So last time when you spoke, you spoke about this sort of desire, this sort of lack that doctors don't want to look at when they move to a functional medicine paradigm because they feel like they're doing great medicine before, where they're just doing sort of the reductionist model. How do we help more doctors to get over that and to start to do this? Because it can be quite intimidating when there's no clear, what do I do?
Yes, that's a great question, because I think that part of what I spoke about last time was how much of a journey, and I think most people here would probably attest to that, how much of a journey coming to this way of understanding human health and pathology really is. That it's not just about, you know, taking a course and hanging a shingle. So I think it needs to come from a place of the empowerment that grows from being able to help patients in this way and being able to partner with patients in this way, and understanding that we don't have all the answers, that there's sort of like something liberating about sitting with a patient and exploring with them how best to help them. So it's a journey, and I think that we have to sort of shed this illusion that it's a body of knowledge that you just acquire and then you go and practice it. That we have to remain open to what we don't know. I mean, a lot of what I just talked about in terms of the treatment model is soft knowledge. You know, it's knowledge that's growing, and it's knowledge that is hopefully going to foster more benign treatments in the interim. But it's it's a process of opening ourselves up to what we don't know and shedding the hubris of what we think we do.
Shedding the hubris is a great turn of phrase. You know, one thing I'm really interested in, maybe if you can stick around, we're going to have a panel at the end. And if you guys want to ask questions with hashtag Functional Forum, you can ask questions at home, or those of you in the audience. One more question before we get on to the next speaker. You know, Mark Hyman has shown significant success with dietary change and those kind of things, using more of a community approach where there's peer support. How do you think that's going to fit into the evolution of mental health?
Yes, I think it's brilliant, and I think it's a place that this must go. Not only because, you know, I like to partner with nutritionists and health coaches and other people who can help me, therapists, holistically minded therapists who can help me implement. Because for me to sit and lecture at my patients about what I expect them to do and what I'd like them to do is largely ineffective unless they have their own internal motivation, that they're bringing to the consultation. So I do think that group work and group support not only is a method of accountability to some extent, which of course is how any behavioral change, whether it's AA or some other model, accountability, but also the sense of community. So the sense that you're not making these changes in a vacuum with all of the uncertainty about whether or not they're actually going to make a difference. So, you know, patients model for one another, and I think that it also alleviates some of the burden of one doctor, one provider, to inspire such dramatic change. I mean, I like to think I can do that, but I don't think it's a very efficient or realistic approach. So I think it's brilliant. I think it's absolutely an innovative direction.